Good morning, dear friends. The topic of our today's lecture is the extrapyramidal nervous system. The extrapyramidal nervous system is responsible for the involuntary and automatic control of all musculature, such as muscle tone, balance, posture, and locomotion. On this picture, you can see how many structures of our brain are responsible for these very important functions. But the main parts of the extrapyramidal nervous system are the cerebellum and the basal ganglia or basal nuclei systems. We start from the cerebellum function, and we start by the cerebellum role in all processes in our organism. The main cerebellum function is regulation of coordination and balance. And the second very important function is regulation of the muscle tone. So, the coordination is provided by the muscle tone regulation. So, the main, very important thing is coordination by cerebellum of muscle actions together with relation of their antagonists. So, as a result, what is the main cerebellum function? The cerebellum subconsciously controls all voluntary movements, providing smoothness and harmonization. I want to revise familiar information about anatomy of the cerebellum, some words also about histology. The cerebellum lies in the posterior fossa, posterior to the brain stem and to the pons and medulla. The cerebellum consists of two laterally placed hemispheres and the midline structure, the vermis. The vermis is the oldest part of the cerebellum, and it is responsible for static or truncal coordination. Hemispheres are the newest structures of the cerebellum, and they are responsible for the dynamic function and limb coordination. The cortex of the cerebellum is much folded. The folds or folia are separated by numerous transverse fissures. Each follicle has a core of white matter and the outer covering of gray matter. The cut surface has a branched appearance called the arbor vitae, tree of life in English. Intracerebellar nuclei. 4 masses of gray matter are embedded in the white matter of the cerebellum on each side of the midline. From lateral to medial, these are dentate nucleus, emboliform nucleus, globose nucleus, and fastigial nucleus. In Latin, nucleus dentatus, nucleus emboliformis, nucleus globosus, and nucleus fastigial. The very important role the dentine nucleus has comparing with other nuclei, because all descending pathways start from the nucleus dentatus. On this picture, this nucleus has a red color. The cerebral peduncles Three peduncles connect the cerebellum to the brainstem. Superior peduncle to the midbrain, and these peduncles are crossed. The name of this cross is Wernicking, and the middle peduncle goes to the pons, and inferior peduncle goes to the medulla oblongata. Superior cerebellar peduncle crossed contains all the cerebellothalamic fibers. Middle cerebellar peduncle contains only pontocerebellar fibers. And inferior cerebellar peduncle contains olivocerebellar fibers, dorsal spinocerebellar tract, and all the fibers connected with the vestibulocerebellum. The cerebellar pathways. The spinocerebellar pathway, so in Latin spinocerebellar, form a method afferent input. These transmit some conscious proprioception from muscles, joints, and skin. Let's revise anatomy of ascending and descending tracts. We know there are two ascending tracts. The posterior spinocerebellar tract or flexic tract. Dendrites, receptors receive information about position and flexion of joints, for example, or muscles in our body, and pass this information to the first order neurons. You remember all first order neurons for absolutely all sensory tracts lie always and only in the spinal ganglion. Axons of these neurons enter the spinal cord, enter the spinal posterior horn, and form ipsilaterally without crossing posterior spina cerebellar or dorsal spina cerebellar or flexic tract from the Clark's cells, which lie, there are second order neurons which lie in the posterior horns. So this tract ascends ipsilaterally and through the inferior cerebellar peduncle. This tract goes to the ipsilateral hemisphere of cerebellum. So, the conclusion: posterior spinocerebellar tract conveys sensory information to the same side of the cerebellum. The second ascending spinocerebellar tract, ventral or anterior or Gover's tract. Do you remember, first order neurons always lie here in the spinal ganglion. Then this tract enters the spinal cord, gray matter, posterior horn and cell bodies of the second neurons lie in base of the dorsal horn of the lumbosacral segments here. Axons of this second order neuron cross the midline to opposite side and then make the superior and then form the anterior ascending spinocerebellar tract up to the pons, and then with crossed superior cerebral peduncle cross the midline again, and this tract goes from the opposite to the same ipsilateral side again and terminates on the ipsilateral side of the cerebellum. So we have the same situation like in case with the dorsal uncrossed flexic tract. Ventral or anterior or Gover's spinocerebellar tract conveys sensory information to the same side of the cerebellum also. Without cross or with cross, the same situation, to the ipsilateral side. Efferent pathways. Only one cerebellum descending tract, tractus dentarubralis, from nucleus dentatus to the nucleus ruber with the superior peduncle. But we know the superior peduncle is crossed. So we go to the contralateral side again. From one hemisphere, for example, right hemisphere of cerebellum, to the opposite, for example, left nucleus ruber in the midbrain, in the cerebral peduncle. Next part of the descending tract, rubrospinal tract, starts from the red nucleus in the midbrain. Then this tract makes a decussation once again, infranuclear decussation, or decussation by Forel decussation. And this tract decussates the midline again and goes down in the lateral funiculus up to the anterior horns, and then with anterior roots exit the spinal cord and goes to the muscles for regulation of their tone and coordination of movements. So, summary. Ascending tracts. In case of posterior tract, this tract doesn't have decussation. In case of anterior tract, two decussations. We start from, for example, left side, and information goes up to the ipsilateral left side. Okay, come down. Dentarubral part of descending tract. One decussation. Wernicke decussation with superior peduncles. And the second part of descending pathways. Manakov tract or rubrospinal tract. Also one decussation. Infranuclear decussation. Forel decussation. So we have again two decussation of descending tracts. And we again come ipsilaterally for regulation of muscle tone and coordination. So, summary. Damage to hemisphere structure always produces signs ipsilaterally to the site of lesion. Compare with, for example, pyramidal tract or somatosensory function. In that cases, we always have contralateral regulation and contralateral signs of lesion. In this case, we have ipsilateral regulation and ipsilateral signs of lesion. So, what are these signs of lesion? Signs and symptoms of cerebellar pathology. The next part of our lecture. The first symptom and the main symptom of cerebral dysfunction is ataxia. Do you remember this Latin word? We described ataxia when we discussed somatosensory pathology, deep pathology, and sensory ataxia. Ataxia means disbalance or disequilibrium. We know several types of ataxia. Sensory ataxia, we discussed. In this case, cerebellar ataxia, maybe vestibular ataxia, cortical ataxia, but I can say the cerebellar ataxia is very, very bright and very difficult and very original in clinical picture. Damage to midline structure, vermis, results in disturbance of equilibrium with unsteadiness of standing, walking, and even sitting. The name of this ataxia is truncal ataxia or sometimes static ataxia. How can we check? By Romberg test. Ask patient to stand with the heels together. Note any excessive postural swaying or loss of balance. In this position, or in this position, hands down or outstretched. Both positions we can use in our clinical practice. You see, swaying ipsilateral to the side of pathology in case of unilateral damage of cerebellum. What is very interesting, eye closure does not affect balance. Why is it so important for us? Because when we discussed the sensory ataxia in case of proprioception pathology, it was said with open eyes, patients can control by vision, by sight, position of their legs, feet, of the ground, and they are always better with open eyes and worse with closed eyes and in the darkness. In this case, eye closure does not affect balance. So, this is a differential diagnosis between sensory ataxia and cerebellar ataxia. Damage to hemisphere structures always produces signs ipsilateral to the site of lesion. The patient complains of impaired limb coordination and walking, dynamic ataxia. Main symptom is ataxic gait. In this gait also doesn't matter with open eyes or closed eyes. This is our patient with cerebellar ataxia, swaying, reeling, unsteadiness during walking. Methods of checking of ataxia in extremities. Upper extremities. Finger to nose test, or sometimes finger nose test. Ask patient to touch his nose with finger. Eyes may be open, may be closed, doesn't matter. Look for two main pathological symptoms: intention tremor and dysmetria. Intention tremor, jockey movements which increase as the limb approaches its target, approaching nose. And dysmetria, overshooting the target when performing this specific motor task. Point-to-point movement evaluation, similar to finger-to-nose test. Ask the patient to touch examiner's finger, but it may be a little bit difficult for patient when we move our finger and ask the patient to touch it. And pathology is the same: intention tremor and dysmetria, overshooting, extra movement. How can we check ataxia in lower extremities? Heel to shin test, or heel shin test sometimes. Ask the patient to elevate his stretching leg, put down to the knee, and move the heel along the shin towards toes. Look for similar symptoms: intention tremor and dysmetria, overshooting, extra movement. This is the picture of this test and our movies.
Видите. Теперь то же самое с другой ногой. Давайте. Стоп.
One more patient, our movie.
Пяточкой попадайте в колено. Проводите вниз по ноге. Резко положительно пяточек коленной правой. Другую ногу таким же образом. Все, уже. Сейчас спину сниму.
There were two patients with alcoholic, toxic, cerebellar ataxia. Chronic alcoholism always affects the cerebellum, and the cerebellar ataxia and cerebellar atrophy on the MRI and CT scanning is a result of chronic alcoholism. The next symptom of cerebellar ataxia in upper extremities, dysdiadochokinesis or kinesia, or adiadochokinesia. In Latin, dysdiadochokinesis or adiadochokinesis. A failure to perform a rapid alternative movement, supination and pronation. Ask the patient to rapidly supinate and pronate the forearms, or to perform rapid and repeated tapping movements. One more, our patient. With adiadocho or dysdiadochokinesia. The next sign of the cerebellar pathology, it's nystagmus. Nystagmus is defined as an involuntary to and from movements of the eyes in a horizontal direction. Eye jerks occur to the site of the cerebellar damage ipsilaterally, like all cerebellar symptoms. This is nystagmus. Eye jerks in horizontal direction. One more symptom of cerebellar pathology, disturbance of speech, scanning dysarthria or explosive speech may occur with speech occasionally delivered with sudden, unexpected force. Articulation is jerky, and the syllables often are separated from one another. Dysarthria occurs in cerebral disease owing to ataxia of the muscles of the larynx. What is it? Scanning. Scanning, dysarthria, or explosive speech. And what is it? Dysarthria? A pathology of articulation, discoordination of articulating muscles, like dysarthria, acute cerebellar disease. So, in case of cerebellar pathology, sometimes patients have a combination of these two variants of speech pathology: scanning speech plus cerebellar dysarthria. For cerebellar pathology, the muscle's hypotonia is typical. Let's revise familiar information. How can we check muscle tones? By passive movements of extremities, flexion and extension. What is it? A cerebellar muscle hypotonia, diminished resistance to passive movements of joints. We can observe, in case of cerebral pathology, Stewart-Holmes rebound phenomenon. Ask the patient, in this position, for example, to flex elbow against resistance. Sudden release may cause the hand to strike the face or chest. due to muscles hypertonia. Pathology of handwriting due to muscles hypertonia, dysmetria, discoordination of hand and fingers due to bold hand. In this case, we have megalographia, writing labored and slow, letters irregular in size and enlarged. Very interesting phenomenon was described by famous French neurologist in the end of 19th century in Paris, Babinski. And Babinski named this phenomenon like Babinski's asynergia. There are pictures from their book published in Paris in 1999, and there were first photos, not pictures, but photos in neurological book with photos of cerebellar patients, ataxia of these patients. What is it? Asynergia. Absence of coordination of organs or body parts that usually work together harmoniously. In this case, asynergia on different muscle groups during performing special motor task. In his original description of cerebral asynergia, Babinski in 1899 presented a patient with cerebral dysfunction performing a backward upper trunk bending. When the patient tried to bend his head and trunk, his lower limbs stayed almost motionless because the associated flexion of the knee and hip, usually observed in normal subject, did not take place. How can we check Babinski's asynergia in our practice? The patient is in supine position, like on this picture or in that picture. Cerebellar patients are unable to sit up from a supine position. The hip flexion is not associated with a leg extension. In this case, the legs are raised above the bed. Babinski also showed several examples illustrating the lack of simultaneous flexion of the hip and knee. There is important to remember that in cerebellar lesions there is no paralysis and there are no sensory changes. Although muscle hypotonia and incoordination may be present, the disorder is not limited to specific muscles or muscle groups. Rather, an entire extremity or the entire half of the body is involved. Then the entire body might show disturbances of muscle action. Even though the muscular contraction may be weak and the patient easily fatigued, there is no atrophy. So, we have discussed the cerebellum pathology, and you see There are two main functions of cerebellum. There are the first function, coordination regulation, balance regulation in organism, and the second function, which can help the first one, it is regulation of muscle tone. For basal nuclei or basal ganglia system, the second main part of the extrapyramidal nervous system, the regulation of muscle tone is the most important function, and we will discuss and describe the anatomy, pathology, functions and dysfunction of the basal nuclei system in the next second part of this lecture. Good morning, dear friends. Today we are continuing to describe function and pathology of the extrapyramidal nervous system. The motor system, main functions of this system are the regulation of muscle tone, coordination of all our movements. During my previous lecture, we discussed the cerebellum function and pathology. Now, we are discussing the basal ganglia or basal nuclei system, paired subcortical masses or nuclei of gray matter. Mostly, these nuclei are located in the subcortical area and also in the upper part of the brainstem. You can see on this picture the thalamus opticus. Thalamus opticus is the somatosensory subcortical center, and we show this nucleus only for location. Now we are located in the subcortical area, just around thalamus opticus area, where all other basal nuclei are located. You can see on this picture nucleus lenticularis or lentiformis, putamen and two globus pallidus, nucleus caudatus, subthalamic nucleus, substantia nigra. Role of the basal ganglia. The basal ganglia play an important, complex and integral role in the control of movements, selecting and maintaining purposeful motor activity, while suppressing unwanted or useless movement, helping monitor and coordinate slow, sustained contraction related to posture and support, inhibiting muscle tone throughout the body. Proper muscle tone is normally maintained through the balance of excitatory and inhibitory inputs to the neurons, then innervate skeletal muscle. This is the line of cut, and then we turn the picture, and now we can see subcortical area, blue color. This is thalamus, only for coordination, somatosensory center, and striatum and pallidum structures. What are they? This is the picture. This is part of our scheme where we show main central nervous system structures. This is level of thalamus opticus diencephalon, and midbrain level you can see cervical peduncle. So just around thalamus opticus, main basal ganglia are located. Caudate nucleus, on Latin nucleus caudatus, nucleus lentiformis or lenticularis, putamen and two globus pallidus in midbrain, nucleus subthalamicus, or Lewis body, nucleus ruber, substantia nigra. The caudate nucleus and the putamen are usually referred to as the neostriatum or striatum. All other nuclei form pallidum, the oldest motor system in phylogenesis. Another name of the basal ganglia system is striopallidoid system. So, if we open this picture again, we can see different colors of putamen and caudate nucleus and globus pallidum. Why? They are different. 4 reasons. The first one, or even 5 reasons. The first one, different structures. The second, different histological structure and different size of cells in striatum and pallidum. Different origin during phylogenesis. Neostriatum, archaeopallidum. Different neuromediators in these 2 structures and different signs of lesion. Biochemistry or neuropharmacology. It was said these 2 structures, striatum and pallidum, have different neuromediators. Acetylcholine is main mediator in striatum and dopamine in pallidum. Acetylcholine, greatest concentration in striatum, synthesized by striatum and has excitatory effect. Dopamine, greatest concentration in substantia nigra pallidum, synthesized by substantia nigra and nigral projections in striatum and has inhibiting effect. Normally, in organisms, these 2 transmitters are in functional balance. Functional concentration of acetylcholine is equal to functional concentration of dopamine. When they are not in balance, we have different syndromes, striatum syndrome and pallidum syndrome. When concentration of acetylcholine is less than functional concentration of dopamine, acetylcholine depletion or dopamine excess results in hypotonic, hyperkinetic syndrome or striatum syndrome, hypotonic, hyperkinetic. In case of pallidum syndrome, acetylcholine excess or dopamine depletion results in the hypertonic, vice versa, hypertonic, hypokinetic syndrome or pallidum syndrome. Some words about hypotonic, hyperkinetic syndrome. You see, hypotonicity plus different types of hyperkinesis, there are typical signs of striatum syndrome. What is it, hyperkinesis? Hyperkinesis means violent movement. Patients cannot hold these violent movements. And in case of striatum syndrome, patients have muscles hypotonia plus different types of hyperkinesis. What are they? The first one is chorea, and involuntary, non-repetitive, irregular, jerking movements affecting limbs and axial muscle groups. Swift grimaces, And sudden movements of the head and limbs are good examples. Causes of chorea: neurorheumatism, side and gums chorea, Huntington's disease, anti-Parkinsonian drugs using, encephalitis, hypothyroidism, hypocalcemia, alcohol. This is our movie. Look at his shoulder. This is chorea.
Скажите сами.
Some words about different types of chorea. Side and gums chorea, or rheumatic chorea, or mild chorea, or chorea mollis. Side and gums chorea is one of the major signs of acute rheumatic fever. Side and gums chorea occurs between 5 and 15 years of age. More females than males are affected, mostly girls 9-12 years old. Clinical features: choreiform movements are not rhythmic and occur sporadically in different muscle groups. For example, a sitting child might suddenly have an arm jerk, upward followed by a leg extension, and then a head nod. The movements occur in such a way that the child is constantly in motion and seems to be twitching everywhere. Treatment of rheumatic fever: rest of body and mind. Sedation may be needed if chorea is severe, and prognosis is very good. Recovery usually in course in 6 to 10 weeks. Relapses not infrequent, especially in pregnancy. Chorea gravidarum. Now, we can have patients with side and gums chorea, rheumatic chorea rarely, because we use during recent decades antibiotics for treatment of rheumatic fever with very good results. Not so good in prognosis disease, the Huntington's disease, or St. Vitus dens, and autosomal dominant disorder with onset in middle age, 30-50 years, and progression to death within 10-12 years. Parents of either sex can transmit, and penetrance is complete. Symptom complex: chorea plus dementia, maybe plus behavioral disturbance, personality change, affective disorders, and psychosis occur. Treatment: we don't have effective treatment. This is hereditary disease. Chorea may be controlled by phenothiazines, haloperidol sometimes. No effective therapy for the mental deterioration. Prognosis: the disease slowly progresses. Death is usually due to incurrent infection, often in special psychiatric clinics. Incurrent infection due to lack of active movements. Often they are bedridden patients due to mental deterioration.
Ну, А детей как ваших зовут?
Левара, старшая дочь и дети. Айдар, 10 и это.
Пройдитесь по комнате.
One more movie, our movie.
Чего боялся? Ну, сумасшедший сделал.
Я вас прошу, пальцем попадаете в кончик своего носа. Так.
Закрыть глаза?
Да, да. Вы можете заставить себя вот не двигать рукой? Ну, давайте попытайтесь. Теперь я вас прошу пройтись по комнате. Встаньте и идите.
Бывают такие минуты, что вроде все, притихло. Ну, потом опять.
Назад идите.
Когда лежу, она нет.
They were two our patients with Huntington disease. And you see all these hyperkinesis are violent. The next type of hyperkinesis, this is athetosis. Irregular, slowing, sinuous, right movements involving the distal parts of the limbs. Result from hypoxic neonatal brain damage or lipid storage diseases, sometimes other diseases. This is the picture of athetosis of hand and foot. This is our patient after stroke.
Так,
Look at
вперед.
his fingers.
Сосредоточьтесь,
Oh.
получается, или сосредоточьтесь. Опустите руки. Еще раз я вас попрошу. Так. Вытяните руки перед собой.
Oh, athetosis.
Хорошо. Это стоит.
Dystonia. Slow, sustained abnormal movement. Generalized dystonia with abnormal posturing of head, trunk, and limbs. Idiopathic torsion dystonia. Or maybe partial or focal dystonia. Examples: spasmodic torticollis, unilateral deviation of the hand caused by dystonic contraction of the musculus sternocleidomastoideus. There are different positions of head in case of spasmodic torticollis. This is our patient with spasm, sustained spasm of musculus sternocleidomastoideus and special violent position of her neck and head. One more example of focal dystonia, writer's cramp and musician's cramp. Task-specific dystonia, meaning that it only occurs when performing certain tasks. Writer's cramp is a contraction of hand and arm muscles that happens only when a patient is writing. It does not occur in other situations, such as when a patient is typing or eating. Musician's cramp occurs only when a musician plays an instrument, and the type of cramp experienced is specific to the instrument. This is a very interesting example of patient. This is our patient, our picture of patient with neuro-AIDS, HIV infection. Typical for this disease is affection of basal ganglia subcortical area. And in this case, you can see dystonia of his Feet. Same patient, dystonic position of the left foot. This is our patient with generalized dystonia. Idiopathic torsion dystonia, this is hereditary disease, and sustained permanent position of patient's trunk muscles, all body muscles. Same patient from his back. This is the picture of the kid with torsion dystonia. Also pictures of patients with torsion dystonia. Other examples of focal dystonia. Hemifacial spasm, characterized by involuntary contraction of facial muscles, typically occurring only on this side of the face. Maybe hemiblepharospasm, only example of focal dystonia. Example of other type of focal dystonia, oromandibular dystonia. Oromandibular dystonia. I can say that now in these cases effective treatment is only botulotoxin using, but is not long, and we are to repeat injections in spasmodic muscles after 6-9 months, but it's really effective. Balismus, a type of involuntary movement affecting the proximal limb musculature, manifested in jerking, flinging movements of the extremity, caused by a lesion of or near the contralateral subthalamic nucleus. Usually only one side of the body is involved, resulting in hemibalismus. In case of hemibalismus, one limb often suddenly flies about in all directions, out of control. Balismus on the picture. What are other types of hyperkinesis? Myoclonus, stereotypies, tardive dyskinesia, tardive dystonia, tics, Tourette syndrome, tremor, volitional hyperkinesia, and other types of hyperkinesis may be present, not often. All these types of hyperkinesis are rare, but you are to know names of these types of hyperkinesis which we can have in case of striatum syndrome. This is our patient after stroke with different modalities
Поднимайте вверх,
of
вверх поднимайте.
hyperkinesis.
Так, ага. В стороны опускайте. Не ходите, не ходите.
Combination of different types.
Так, положите на коленочки. Пальцем кончик носа показывайте. Давайте. Опустили. Соедините пальчики вот так, противопоставьте друг другу. Вот так делайте. Давайте. Хорошо.
The second part of our lecture about basal ganglia system is pallidum syndrome, hypertonic hypokinetic syndrome, or Parkinsonism. You remember we can have this syndrome in case of dopamine depletion. You are to know 4 main syndromes of Parkinsonism. The first one is rigidity, extrapyramidal muscle hypertonicity, stiffness felt by the examiner when passively moving a limb. There are 2 types of rigidity. plastic or lead pipe rigidity, a steady increase in resistance throughout the full range of movement, affecting flexor and extensor muscles groups equally. Do remember one more type of muscles hypertonicity: spasticity. Spasticity patients can have in case of pyramidal system upper motor neuron pathology. Do remember clinical characteristics of spasticity. When we check the muscle tone, we have clasp knife phenomenon. When we feel resistance only at the beginning of every movement, at not equal distribution of muscles hypertonicity, more evident in arm flexors and in leg extensors. And due to this muscle tone distribution, patients after stroke with hemiparesis have a Wernicke-Mann posture with flexed arm and extended leg. In this case, we have absolutely another type of muscles hypertonicity: rigidity. Rigidity is typical for extrapyramidal hypertonicity, spasticity for pyramidal hypertonicity. In case of rigidity, patients have equal distribution of muscles hypertonicity throughout the full range of movement, affecting flexor and extensor muscle groups equally. The second is a cogwheel rigidity, a ratchet-like increase in resistance when tremor is superimposed upon rigidity, like on the picture. So, I want to compare on this slide different modalities of hypertonicity. You are to distinguish them. In case of spasticity, type of elevated muscle tone produced by lesion of the pyramidal pathway, the resistance of a spastic upper limb to passive movement is usually strong at first, but may then suddenly give way, clasp knife phenomenon. Alternatively, it may increase on continued passive movement. Rigidity is a viscous or voxy resistance to passive movement that can be felt to an equal extent throughout the entire movement. And cogwheel phenomenon, like on the picture. We can see patients' hypokinesia due to muscle spasticity, muscles hypertonicity. There are terms describing hypokinesia and oligokinesia of patients with Parkinsonism. Hypokinesia, loss of voluntary movement. Bradykinesia, slowness of voluntary movement. Oligokinesia, movement number decrease. Acherokinesia, arm swinging amplitude decrease when walk, and extremities are situated close to trunk. Shuffling gait, small rapid steps to keep up with the center of gravity. Flexed bent posture, reduced facial expression like mask-like face, reduced blinking. This is typical appearance, posture, habitus of Parkinsonian patient. Mask-like face Extremities are located close to the trunk. Same patient standing. Mask-like face. Expressionless face. The third sign of Parkinsonism. This is tremor. Tremor of rest at a rate 4-8 per second. Peel rolling, cause and character, distal in distribution, the thumb moving rhythmically. It occurs at rest, improves when movement, and disappears during sleep. It begins unilaterally in case of Parkinson's disease, in the upper limbs, and eventually spreads to all 4 limbs. This is our patient with the initial stage of Parkinsonism, unilateral tremor.
Назад идите.
Typical Parkinsonian
Назад идите,
rolling
назад
tremor.
поворачивайте и идите. Назад идите, ко мне идите.
Peel rolling,
Вы принесли в своей жизни?
unilateral.
Практически таких серьезных никаких, кроме простуды.
Вас не оперировали?
Ну, писем сечение, да?
И все, да? В инфекционных больницах вы никогда не лежали? Скажите, пожалуйста, у родственников, у мамы, у папы?
Also typical
хорошо.
peel rolling tremor, Parkinsonian tremor. And the fourth big group of symptoms, there are postural disturbances. Flexion of limbs and trunk is associated with a failure to make quick postural or writing adjustment to correct imbalance. The patient falls whilst turning or if pushed, propulsion, lateral pulsion, and retropulsion we can observe. This is typical appearance of Parkinson's disease. Masked facial expression, special bent stooped posture, rigidity, forward tilt of trunk, reduced arm swinging, flexed elbows and wrists, small steps, shuffling gait, sometimes trembling of lower extremities, slightly flexed hips and knees, typical habitus of this patient. This is very, very good old movie.
If the disease involves both substantia nigra, there is difficulty in correcting posture when suddenly displaced. This man literally falls backwards when he is lightly pushed. In a healthy subject, rapid passive stretching of a muscle is a smooth movement. In the patient, the stretching is interrupted and is called cogwheel. The volitional movements in the patient are definitely slower than those in the healthy subject. When the patient's hand is placed on his leg, a regular tremor develops in his fingers, thumb, and at the wrist. This tremor is likened to pill rolling. As he walks towards us, the steps are short. The gait is somewhat shuffling. The patient turns slowly. And he sits down awkwardly in a lump.
Classification of Parkinsonian syndromes by Jankovic. 80% this is idiopathic primary Parkinsonism or Parkinson's disease. 10% secondary Parkinsonism, drug-induced, for example, neuroleptics like haloperidol, vascular, 2%, for example, after stroke, post-infections, toxic, for example, carbon monoxide, manganese, Wilson disease, and 10% plus Parkinsonism or Parkinsonism plus. This is a group of hereditary diseases when patients have Parkinsonism plus anything else. For example, progressive supranuclear palsy, Parkinsonism plus oculomotor disorders, corticobasal degeneration, Parkinsonism plus mental disorders, or something else, 10%. Some words about typical Parkinson's disease. Described by James Parkinson in 1817, he published an essay about shaken palsy. In this essay, he described 6 patients with typical Parkinsonian picture, and he was one of these 6. He suffered from this disease, shaken palsy, and after 50 years, famous French neurologist Charcot proposed to name this disease after James Parkinson. So now we say Parkinson's disease. The cause of Parkinson's disease, unfortunately, is unknown. You can see on the picture incidence, prevalence, sex incidence. I want to draw attention, age of onset, 50 years upwards, rarely earlier in age. Clinical pictures, typical Parkinsonian syndromes. But their first symptoms are unilateral. This is typical for Parkinson's disease. Treatment is symptomatic. It does not halt the pathological process, but really can help. It aims at restoring the dopamine and acetylcholine balance. We know we have dopamine deficiency. And so the first method, we try to increase dopamine and give it an exogenous dopa. We give levodopa or levodopa plus inhibitor of side effects, or sometimes we can help with dopamine agonists. A lot of side effects and a lot of problems during usage of levodopa exogenously. Other drugs which we use for treatment of Parkinson's disease. And now we use new methods, surgical methods. One of them is deep brain stimulation, DBS, surgical treatment involving the implantation of a medical device called a brain placemaker, which sends electrical impulses to specific parts of the brain. DBS in select brain regions had provided remarkable therapeutic benefits for otherwise treatment-resistant movement and affective disorders such as chronic pain, Parkinson's disease, tremor, and dystonia. The FDA improved DBS as a treatment of essential tremor in 1997, for Parkinson's disease in 2002, and dystonia in 2003. On the picture, insertion of electrode during surgery using a stereotactic frame. Stereotactic surgery or stereotaxy is a minimally invasive form of surgical intervention which makes use of three-dimensional coordinate system to locate small targets inside the body and to perform on them some actions such as ablation, biopsy, lesion, injection, stimulation, implantation, radiosurgery, etc. DBS stimulator produces electrical impulses that affect the nerve cells around the electrode and should help alleviate tremors or symptoms that are associated with the affected area. There are a few sites in the brain that can be targeted to achieve different results, so each patient must be assessed individually and a site will be chosen based on their needs. Traditionally, the two most common sites are the subthalamic nucleus and the globus pallidus interna, but other sites such as caudal zona incerta and the pallifugal fibers medial to subthalamic nucleus are being evaluated and showing promise. The major complications vary, include hemorrhage 1-2% and infection up to 3-5%. And one new method, this is duodopa intestinal infusion system, treatment of advanced levodopa responsive Parkinson's disease with severe motor fluctuations and hyperdyskinesia, when available combinations of Parkinson medicinal products have not given satisfactory results. Duodopa is gel with continuous intestinal administration. For long-term administration, the gel should help administered with a portable pump directly into the duodenum or upper duodenum by a permanent tube via peritoneal endoscopic gastrostomy with an outer transabdominal tube and an inner intestinal tube. Alternatively, radiological gastroionostomy may be considered if a peritoneal endoscopic gastrostomy is not suitable for any reasons. Thank you for your attention.